when we got asked to kind of give this presentation, we talked about learning objectives being describing the complexity of diagnosing dementia and the importance of early detection. I'm going to start by talking about the importance of early detection because that's something I'm passionate about. Plus, we have a couple other providers on the panel that I know are going to go into greater details on diagnosing. So I'll squeeze as much as I can in here in my 15 to 20 minutes and then see where we go. I don't have any disclosures to talk about. I'm going to start off by talking about cognitive decline. What is cognition and cognitive decline? Cognition is thinking. It has to do with memory, language, problem solving, executive functioning, everything our brain does. And we usually separate that out from emotional functioning, even though mood does have something to do with cognition. When I'm talking about cognition, I'm talking less about feelings and more about thinking. Cognitive decline does happen in normal aging, age-related cognitive decline, and then we have clinical decline. And today I'm going to talk mostly about clinical decline. We typically lump the degree of decline and the way it impacts daily functioning into two categories. The first is mild cognitive impairment, also termed mild neurocognitive disorder. And then the one that we're all here to learn a little bit more about is dementia, also termed major neurocognitive disorder. And although there are plenty of different things that can contribute to a diagnosis of dementia and mild cognitive impairment, many things that can cause it, mild cognitive impairment itself, or MCI, is defined by a change in cognition, meaning that you're not at your normal level of functioning that's not just due to normal aging, and that the person remains independent in activities of daily living. So there's some kind of change, but it's not really interfering with one's ability to get by. Now, when those deficits or changes in cognition progress and then they influence a person's ability to independently engage in decision-making and activities of daily living, then it meets that criteria for the label of dementia, also termed major neurocognitive disorder. There were some changes in the labeling around 2013. And we used to have to identify specific changes in memory. Now that's become more general to just be changes in any aspect of cognition. This has been beneficial to aid in differential diagnosis and getting the diagnosis of mild cognitive impairment or dementia in place sooner or more accurately at an earlier time. Because as we know, not all neurodegenerative conditions start with memory difficulties. As Abby discussed, frontal temporal dementia, we see changes in behavior, psychiatric symptoms first. Now, as long as we see some changes in cognition, we can identify that as mild cognitive impairment, even if it doesn't include memory yet. This has been pretty beneficial for early identification. And so, now I'll go into greater detail a little bit on these activities of daily living that I talk about. What are activities of daily living? It's important that we define these specifically because it is the difference between mild cognitive impairment and dementia. So a person can have quite significant changes in cognition and still not meet that label of dementia if they're able to take care of themselves, engage in activities of daily living independently. So basic ADLs, or activities of daily living, are the things that we need to do that are necessary for survival. Eating, engaging in personal hygiene, dressing, using the restroom, and complex or instrumental activities of daily living are things that allow for more independence. Management of healthcare, finances, taking care of one's home. This includes things like medication management, ability to engage in financial decision making and keeping oneself safe and free from scams, although that can happen even without cognitive changes. Being able to maintain a sanitary living environment, so housework, use of communication like the phone, and use of transportation. Not specific to driving. Can you figure out how to navigate the process of getting a cab or riding the bus or other things like that? And I'm just going to touch on this again. The reason why activities of daily living are so important is because the longer we are independent in activities of daily living, the farther we can push out the diagnosis of dementia. So the longer a person stays in that earlier category of that mild cognitive impairment right here. And that's the goal. Even if we know changes are due to Alzheimer's disease, we want to help an individual stay in this MCI range where, yes, there's changes in cognition, but it doesn't influence a person's ability to stay independent. And often the goal is to stay within that range as long as possible. Early detection is important. Because there are many conditions that can cause memory changes or changes in cognition, or MCI, that are reversible. It's not always Alzheimer's disease, and that insight is important. Because if I had memory difficulties and it wasn't Alzheimer's disease, I would definitely want to know. For one thing, sleep apnea is a cause of changes in cognition. What we do know is that a little bit of sleep apnea, doesn't even have to be severe, but just a little bit of poorly controlled sleep apnea can influence, or a mild degree can influence cognition. It slows us down, makes it harder to retrieve information from memory, makes it harder to hang on to multiple pieces in short-term memory or attend to what somebody is saying. Depression and anxiety are also causes of changes in cognition, including memory that can mimic Alzheimer's disease or other forms of dementia. That's why it's important to go check with your doctor early, figure out if there's another cause of these cognitive changes that might be reversible, can get a person back to their 100% if we treat them. Hydrocephalus is another cause. That's a condition where the fluids are not flowing as they should throughout the brain, and extra pressure develops, which causes some changes in gait, motor movement, and cognition. Definitely a treatable condition. High blood pressure can cause changes in cognition. We know that it can be associated with, it can cause strokes, but there's also a more general pattern of cognitive changes that can occur due to poorly controlled blood pressure for prolonged periods of time. Medication can be a cause of cognitive changes that's not a dementia syndrome or a neurodegenerative condition. And then some metabolic condition, as well as inadequate vitamins. So if your D's and your B's are low, that can cause changes in cognition as well as functioning, motor functioning as well. So that insight, early detection is important. For one, it might not be Alzheimer's disease, might not be a condition that's going to progress and get worse. There are therapies that can help, whether it be medication therapy, speech therapy, for rehabilitation of cognitive dysfunction, and occupational therapy. There are also some lifestyle changes that I'll go into greater detail with here in a little bit. You know, it's common as humans for us to focus on our weaknesses and end up neglecting our strengths, when really, when there are changes in cognition, the goal would be to accommodate the changes in memory or other aspects of functioning. Focus on strengths, accommodate those weaknesses to be able to engage in daily activities. And then I'm going to talk a little bit more about modifiable risks as well. So some modifiable risks related to medical conditions are diabetes. The better control of diabetes we have, the less likely one is to develop cognitive changes. We know that diabetes is a risk factor for cognitive decline and can also lead to earlier detection of earlier changes in cognition, greater memory difficulties at an earlier time than one would develop them if they didn't have diabetes, weren't smokers, didn't have obesity, didn't have high blood pressure, or didn't have poor sleep. Sleep is one of those modifiable risks that's very important. Poor sleep can cause changes in cognition. It can make changes in cognition worse if they are due to Alzheimer's or Lewy body, another change. And it's also it's modifiable, whether that be due to sleep apnea. You know, if you're snoring a lot, you're not likely getting as deep a sleep as you need, because that arouses us, and then we're not getting the quality of sleep that we need. These are all things that can be modified that reduce the risk of getting dementia, reduces the risk of transitioning from mild cognitive impairment to dementia. So it's important to see your doctor to make sure none of those are influencing cognition as well. Those are things we can keep track of. It's important to identify concern about cognitive changes earlier, because we do have memory enhancing medications. That's kind of what they're referred to. Really, they don't enhance a whole lot, but what they do is they slow down the progression of the illness. These medications got kind of a bad rap when they first came out because people don't really notice significant benefit. They say it's about 8% of individuals that notice a significant improvement. But what we know about these medications is that they slow down the progression of the illness. No, they don't cure it, but using memory medications allows a person to maintain independence in activities of daily living for a longer period of time, which in turn delays the transition from mild cognitive impairment to dementia and also means increased time at home. So delaying time from symptom onset to needing skilled care. What's most important was already kind of touched on it in Abby's talk, was that the earlier we can get these medications on board, the more effective they are in slowing the progression of the illness or decreasing the rate of progression of cognitive changes. What we really want to see is that medication started while a person is still in the MCI phase. So before it influences their ability to engage in independent cares and take care of themselves and do those activities of daily living. It doesn't mean that it's not beneficial if it started later. It definitely is, but the earlier you come in and get assessed and we identify that potential change, the quicker we can start on a medication that can possibly be beneficial. All right, big four is what I call these. These are modifiable risks that have to do with our daily activities, lifestyle choices specifically, structure and routine, socialization, exercise, and heart-healthy diet. Let me talk about those a little bit more. So exercise, first let's talk about physical activity. Increased physical activity is known to decrease risk of developing Alzheimer's and other forms of dementia. Most of the research is on walking. If your heart doctor is telling you to do a little bit more, then I definitely listen to them. But a lot of the research to date is on walking. So if your doctors are telling you to do cardiac activity, that's great. Definitely listen to them, but don't feel bad about it. As long as you're walking, engaging in some physical activity, that is going to be beneficial. The goal, what we know makes the biggest impact, is to walk at least 2 miles a day. That actually decreases the likelihood of cognitive decline and changes just the structure of the brain, but there is a dose-response relationship. So a little bit of walking means a little bit of decreased risk of cognitive decline. A lot of walking means a greater decreased risk. So any little bit counts. The more you do, the better it is. And the research also demonstrates that adding exercise at any time in one's life decreases the risks of cognitive changes. So the hidden message there is start now, but if you haven't yet, but even if there are already cognitive changes, it's important to get your patients or your loved ones started in that activity at any time. And just one quick comment on sitting. There is some research indicating that the amount of time that we spend sitting places us at increased risk of cognitive changes. So at least make sure that you're getting up and walking around, moving at least once an hour, and the less sitting you do, the healthier, or the decreased likelihood of developing cognitive changes over time. So physical activity we talked about. Now let's talk about cognitive activity or intellectual activity. Research, what we know is that you want to engage in a diverse array of cognitive changes to quantify as a modifiable risk or decrease that risk of cognitive decline. Reading, crossword puzzles, playing musical instruments, going to a museum, school, volunteer activity. What we know is people who are more involved in mental activity tend to show fewer cognitive changes. And that's noticeable earlier in life and are at a decreased risk of developing dementia later in life. And then social activity. Social activity is like exercise for the brain. It takes visual input when you're looking at other people. There's language-based input. You're using some executive functioning to track the conversation, decide whether or not you should say what you're thinking, holding some of that information back. It's definitely a cognitively demanding activity, and it is very healthy. really what we also want to do is avoid isolation. So that cognitive activity is important, but also not being isolated. And in these pandemic times, know that phone, Zoom, video conferencing are effective. It's good to be in person, but any type of interpersonal activity is healthy brain activity. And this is something that individuals should plan in their routine. Instead of saying, I think I'll call my daughter on Wednesdays, you should encourage your patients or loved ones to set that up as a routine, talk with their daughter, have a standing appointment for that social activity or with whomever that might be. And routine. So what we know is that individuals that maintain a consistent routine of daily activities, these activities of daily living, if you can do your personal cares essentially with your eyes closed, then we're going to delay the diagnosis of dementia for years. What does that mean? That means longer time living independently or being able to engage in activities that they want, having a greater understanding of what's going on in them, longer period of quality of life for a greater period of time. So that means maintaining a consistent sleep-wake cycle, regularly scheduled meal times, and engagement in personal cares, and then a consistent time for medications. What we don't want to see is individuals waking up thinking, what am I going to do today? I'm retired. I can do whatever comes to me. Nope, that's not healthiest for your brain. Your brain wants routine. We're the same as those little kids that get kind of ornery when they're missing a nap or when their schedule changes, but we use our cognitive strengths to compensate for those feelings so that we're not crying or yelling at people. But if there are changes in cognition, you don't want to have to compensate. You don't want to use all your mental activities and your best for just figuring out how do have I taken my medications yet? Where did I leave my deodorant? I can't remember if I brushed my teeth. Those things should be all so automatic that it doesn't take a lot of cognitive activity or strenuous cognitive engagement to walk through them every day. So they should be absolutely consistent from one day to the next. And that frees up space for engagement in other activities. So getting information into memory, getting things to stick, being able to retrieve information from memory. So those are kind of my slides on early detection and modifiable risks. Here's the kind of the main take home that I want individuals to understand here. I've seen that the earlier a person comes in and identifies these changes, and the earlier they set up a consistent routine, are engaged in regular cognitively demanding activity and physical activity, the longer a person's going to stay at home, stay healthier, and we're going to push out that diagnosis of dementia. I've seen folks who come in early and, and they show signs of mild cognitive impairment, and it really looks like Alzheimer's, or it really looks like it's going to progress to Lewy body dementia. And when they instigate these different things, when they have a consistent routine, are engaged in socialization, are treating depression, are treating those modifiable risks, and getting good quality sleep, these folks do really well for much longer than individuals that don't. So the goal is to identify symptoms early, get that structure and routine, plus healthy cognitive engagement and possibly a medication on board. And by doing so, we're going to decrease or we're going to prolong the period of mild cognitive impairment and delay that transition to full-blown dementia, and therefore have a longer period of time with great quality of life. So when an individual is referred to me for testing, we definitely go through all the background and history, make sure that I know that person well, as well as things that they've been good at, things that they haven't been good at over time, as well as psychiatric history. And then I look to see if there's anything else that might be contributing to cognitive difficulties, life situations, different type of medical conditions. And then when a person comes in for testing, I do an interview with them and first figure out what kind of concerns are going on with memory. I'm looking for complaints about difficulties with new learning, getting new information to stick, or is it actually retrieving it? I know this, I just can't pull it up. It's not there right when I need it. Or does it have more to do with working memory or attention? When I walk into another room, I forget what I went in there for. And then when I come back out, I remember what it was, but I always get up and I forget what I was getting up to do. And then using memory to execute different things, like remembering how to carry out overlearned tasks. We also look at language, word finding, the feeling of I know the word, it doesn't come to me until later. Executive functioning is I ask questions about one's ability to carry out complex activities. Insight, are they aware of the difficulties, or is this more likely, or is it more commonly something that other people are noticing and the patient's not aware? And then a visual spatial functioning that maps onto real world assessment of recognizing family members, knowing where you are in town, being able to recognize your own home or your living space. So then when a person, after I've kind of figured out what they're experiencing, we have them work with a technician. They're called a psychometrist. And that's where we do different tasks that look at every area of cognitive functioning. And these tasks are adjusted for one's age, for their personal history that I got from that interview, which includes education and some other aspects. And then we do tasks that test out different areas of how the brain is working. We're going to, as far as memory goes, we look at how much information a person can hang on to. Can they hang on to it and manipulate it simultaneously? We'll ask a person to remember language-based information, so kind of a grocery list type of thing, and then we'll do stories. And what that maps onto is real-world new learning. Are we able to get new information to stick? Once it's there, how well can you pull it up? Or is it in there, you just can't access it when you need to?
You want to watch you want to go to sleep?
Yeah.
And then we also look at do tasks that look at different aspects of executive functioning. So I look at planning, organization, problem solving, response inhibition. And these are all different tasks that when a person comes in and they're doing them in the office, they might seem kind of goofy. You might think, I don't think this measures anything related to how I function outside of this setting. But that's okay. That's the goal. We're just doing different tasks that are pretty specific to how different parts of the brain work. Most of these tasks start simple, then they get progressively more difficult until a person can't do them anymore, which is kind of why nobody really enjoys neuropsych testing, is because we are going to test the limits. But what I'm looking for is identification of different pattern of strengths and weaknesses. So the pattern of strengths and weaknesses identified in testing is different for an individual with Alzheimer's disease versus somebody with Lewy body disease versus somebody that might have changes due to vascular health, stroke, or other changes, and different from Parkinson's. So I'm looking for a different pattern of strengths and weaknesses. Oh, and of course, I can determine whether or not this is just normal aging, which is the answer we're all hoping for. And yes, if you're worried about whether or not it's normal aging or it's clinical cognitive decline, that is a great reason to come in, because if it's normal aging, we deserve to know that. And because that worry itself, the concerns that somebody has about their memory can spiral and can cause additional memory difficulties, and everybody deserves to know whether or not there are changes, or their family members should know that so that they can provide support. We can also do differential diagnosis to figure out, are a person's changes in cognition or their symptoms that they're experiencing or others are viewing, are those due to it might be due to depression or anxiety, very treatable causes, like I mentioned. And so we're trying to figure out the pattern of strengths and weaknesses to figure out what the underlying cause of this dementia syndrome is, or the memory difficulties.